for our anxiety disorders, we're going to cover generalized anxiety disorder, panic disorders, phobias. We will mention obsessive compulsive disorder and post-traumatic stress disorder, but we're going to mention them very briefly, and they have little asterisks here because they used to be grouped as anxiety disorders. So with the DSM-4, they were anxiety disorders, but now with the DSM-5, they're actually in their own separate categories. But rather than complicating things and adding even more categories, I've just left them here with an asterisk. Because we only spend, I think, one slide on each of them. So we're acknowledging that they've been relocated since. But if we're going to talk about anxiety disorders and specific anxiety disorders, we can talk about them large scale, and we want to acknowledge that because people look at, oh, anxiety, that's just, I'm kind of apprehensive. I feel worried or upset about something. But it's a lot more than just feelings of apprehensiveness. It's a lot more than being worried about a legitimate threat. It tends to get into that sort of excessive worrying. So excessive apprehension. So things are out of proportion to the events, the stimuli that are triggering them. So a lot of this and a lot of the disorders we talk about are basically taking, say, a normal reaction, but blowing it entirely out of proportion. So to the point that it is causing distress or damage or danger or any of those other problems that we talked about in our diagnostic criteria. So we typically see lots of out of proportion responses, and we're going to have emotional and physiological and behavioral and cognitive components that make up those types of responses we could have. So breaking those down, with our emotional responses or emotional symptoms, our components there, we have feelings. We are maybe feeling apprehensive, we are feeling tense, we are feeling worried. In the cognitive symptoms, maybe we're worried about something specific. Maybe we have thoughts that are contributing to this. Maybe we're cycling through a bunch of negative thoughts. Maybe we're worried about our inability to cope with a scenario, or worried that a scenario will come up that we can't handle. For this physiological side of things, we get standard fight or flight responses, increased heart rate, muscle tension. Our autonomic nervous system is all activated. We're prepared for what we perceive as a legitimate threat, even if we could logically evaluate it as not actually threatening. But our bodies respond as if it were. So a lot of this is effectively just a long-term fight or flight response in the absence of a stimuli that should be triggering it. And then with our behavioral symptoms, what are we actually doing? We might see a reduction in our task performance. We might be more easily startled because we're activated and worked up. We might start avoiding situations that could trigger some of these behaviors. So we start seeing an adjustment in how we act based on all of these other components. And so all of these work together to create our different anxiety responses. So for the specific disorders, generalized anxiety disorder is kind of what it sounds like. It's generalized. It doesn't have a particular target. So we have, again, excessive worry, but it's not linked to any particular situation or object. There is no specific threat, but we're going to have chronic high levels of anxiety that's kind of a free-form floating anxiety. We can't tell what's going to go wrong, but we feel like something's going to go wrong all the time. So constant feelings of dread, and we get a lot of our fight or flight responses. So we might get dizzy because we're breathing really quickly and our heart's beating really fast and our blood pressure is through the roof. We might be exhausted because we're in this fight or flight mode all the time. We might have some muscle weakness or trembling because we've been worked up for so long. So we can kind of think of this as, well, if it's going on all the time with no way to relax because we don't have a source, it's definitely going to cause some problems, especially with what we just saw about how our bodies react to stress. For this one, it typically actually starts a lot earlier than other anxiety disorders. So most of the ones that we'll talk about tend to start in early adulthood, early to mid-adulthood. But generalized anxiety starts in sort of middle age, meaning more like teenage years into early adulthood. So there are some theories that this actually might be like a diffuse state of worry that actually leads into or precedes other anxiety disorders. So you might start with generalized anxiety and then prescribe it to, say, a particular phobia or a particular situation. We're going to start seeing this pattern where most of our anxiety disorders are actually much more common in women than men. And we can have a debate about whether this is because of some biological factor or if it's a cultural factor. Because if we think about how we are taught to express our emotions, it's probably a lot more culturally acceptable for a woman to express being worried about something, whereas a man might be told that he just needs to suck it up and deal with it. So those cultural norms can dramatically change what we would admit to, and can therefore influence our diagnoses. So for some of our statistics, about 1/3 of people who develop this disorder, it's actually triggered by a stressful event. And it could be a positive or a negative stressful event, but it's usually something that gets them worked up, and then they stay worked up with no reason for it to stay. So it could be from an illness, or from a wedding, or from a promotion, or from a situation of abuse. It doesn't really matter. It's just being worked up has led to this to occur. About 5% of the population between the ages of 15 and 45 will have this disorder. So it's a pretty common disorder. And it's very often comorbid with other disorders, especially other anxiety disorders, which is why they also think that it might be that starting point for other anxiety disorders. It can also end up being comorbid with things like alcohol abuse and other substance abuse, because these individuals are usually looking for a way to reduce those feelings of anxiety. So if they go non-traditional ways to self-medicate, it can cause problems. And this one actually has a cultural bias where it is much less common in Latino, Asian, and Black individuals. But most of the research actually leans towards that being a diagnosis bias, and possibly because of a lack of access to places you could receive a diagnosis. And that is not exclusive to this one particular disorder. All right. Next, we get our phobias or phobic disorders, depending on their terminology. A bunch of our disorders are named after like Greek gods or mythos. So here, this is named after the Greek god Phobos, who was the god of fear. So they used to put his image on armor to scare people. And so they adopted the term to talk about these intense, persistent, irrational fears of objects or situations, stuff that poses no real threat. So once again, an out of proportion fear response to something that is not actually threatening. And there are tons and tons of different types of phobias. I always list a couple, so we'll have things like acrophobia, the fear of heights. That is something that I dealt with for a very long time, possibly because I got very tall, very young, and fell over a lot as a consequence. I have had to work through that. Claustrophobia is another one, fear of small spaces. Brontophobia is fear of storms. Hydrophobia, fear of water. There's a whole bunch of other ones. Coulrophobia is fear of clowns. They have tons and tons of lists of different types of fears. So these often develop during childhood or adolescence and tend to persist over time. So phobias are usually going to have a particular trigger. There's usually some event that starts it, but not always. The degree of impairment dramatically affects or is dramatically affected by how often you encounter this thing. So if you have a fear of heights and live on the ground floor, maybe it's never going to bother you. But if you have a fear of heights and you are an airline pilot, then it's probably going to cause some problems. With a lot of these phobias, it is very, very rare for them to go away on their own, especially because people often engage in avoidance behaviors. So I'm afraid of heights. I will only go to ground level things. And if you find that, hey, this place makes me afraid, I'm gonna leave, and then I feel better, we end up with our operant conditioning. So once again, negative reinforcement to do that more often. So a lot of our fears can be negatively reinforced, and it causes problems. So typically we'll have to go through some kind of exposure therapy, which we'll mention in the next chapter. And one of the problems with this is that people know that these fears are irrational, so they can logically say that, well, like, it's probably not going to cause problems. But in the moment, when exposed to it, they can't stop that fight or flight response. So they can know and be aware that this isn't something they should be afraid of, but that doesn't mean they have any control over it. And this is another one that's fairly common, where up to 10% of the population will have some form of phobia across their lifetime. So it is really, really common to have. And again, mostly women, so 2/3 of people with these phobias are women, which again could be a diagnostic thing or a cultural thing or a biological thing, we're not quite sure. In Western society, we see a lot of agoraphobia, which is fear of open spaces or public spaces. That's actually going to become really important when we get into our panic disorders in a moment. Social phobias would be fear of certain social situations where people worry about how they interact with others and how others will sort of see them. And then when we talk about specific phobias, that would be things like arachnophobia, you're afraid of spiders. I don't know what the one is for snakes, but that's also another really common one. But those specific phobias tend to be fairly common as well. Whew. So we get to fly through stuff in this chapter. It's a lot, but it's kind of neat to see them all. With our panic disorders, the next of these, again, named after a Greek god, this time Pan, specifically because he was a mischievous deity that liked to jump out and scare people. That's how he passed his time. And so they were like, aha, you terrify people with no warning, that's perfect. So our panic disorders are going to be recurrent, intense instances of anxiety that often have a sudden and unexpected onset. Almost always they're going to come along with panic attacks. So panic attacks are unexpected, anxious feelings that can ramp up in intensity, and we can end up in this sort of, we are afraid or even terrified. So panic attacks can have really, really massive impact on people. Panic attacks aren't exclusive to panic disorders. They can occur with all of the other anxiety disorders, can also occur with mood disorders and eating disorders. They're kind of ubiquitous that way. And typically we want to sort of separate between panic attacks and anxiety attacks, where a panic attack is usually a lot more intense, and it's typically something that sort of comes up suddenly. Whereas an anxiety attack is usually triggered by a certain stressor, it's usually directed at something, and it's usually a lot less unexpected. But both can happen. One of the biggest problems with a panic disorder is that once it starts and you have these panic attacks, it can then interact with things like agoraphobia and social phobias, where now you start worrying about having panic attacks in public. And so now you're afraid of going out in public in case you have a panic attack. And that heightened level of anxiety actually makes you more likely to have them. So it kind of becomes like a self-fulfilling prophecy. So we start seeing more anxiety, people start getting apprehensive about trying things and going out and doing things. They might start becoming hyper-vigilant to try and keep it all under control. And once again, more common in women than men. This one is not as common as some of the others, only about 3.5% of the population. Still not an insignificant number, but not as bad as some of the others. This actually seems to show some correlations with attachment styles, where if you grew up with uncertainty, so if your parents weren't able to give you security in your attachment styles, you're a lot more prone to this particular disorder. Again, correlations, not necessarily causation, but it's there. And here we see it develops late adolescence or early adulthood, so a little bit later on in time. So what do we think is actually driving these anxiety disorders? And for each of these categories, we actually tend to find fairly often they have similar factors that tend to be involved, which is why we get to talk about sort of biological factors for all of these disorders. So we are fairly sure that there is going to be a genetic component because there have been multiple twin and adoption studies that show that our monozygotic twins or identical twins are more similar in their diagnoses of anxiety disorders than dizygotic twins. We also start seeing some specific biology involved where low levels of one of our neurotransmitters called GABA actually correlates to having a more reactive nervous system. So GABA is it's one of the primary inhibitory neurotransmitters in the brain. Inhibitory meaning that it's supposed to calm down or reduce firing rates. So when we have low levels, we're not able to control that, which means that if we get an incoming stimulus, our brain is going to respond faster and maybe more aggressively than it needs to. So it's going to be involved, or it's at least correlating with being more reactive for these disorders. For cognitive factors, there's a lot of thinking patterns that go into anxiety, where once you start with that worrying and that cycle of worry and what if, we can actually get into very maladaptive thought patterns. So individuals with these disorders might be a lot more likely to think catastrophically. So they are going to assume that the worst is going to happen. So even if they haven't had a panic attack in public for a very long time, they would think things like, oh, well, I'm due to have one. Not that I'm getting better, but that if it's been this long, then it's my time. So that can be really problematic. Of course, our psychodynamic individuals would have a different interpretation. I sort of mention them as an aside because they're more Freud's theories that don't really have evidence. He related it to neurotic anxiety, basically where we have tons of those impulses that are trying to break out and we can't do anything to prevent it. So we start having anxiety because we can't suppress I think it's the id is the lowest level. So that's what they propose is going on. But of course, we don't have evidence for that or any way to test that. We just get to see the aftermath. Hence, not so much putting it on the slides. For our environmental and learning factors, we're going to find that a lot of these have a learned component. So we've mentioned the whole classical conditioning side of things, positive reinforcement for some operant stuff as well. So for classical conditioning, if there's a situation where you experience pain or trauma or something that actually should cause anxiety and worry, you then start associating the place where that happened or the object nearby when that happens with those bad feelings, and then it'll automatically come to mind. And then if we start looking at the operant conditioning, where leaving a place that makes you anxious makes you feel better, you're more likely to do it. We also can include modeling, where we watch others. And this is a huge one with anxiety disorders. So if you watch your mother be afraid of spiders, as a child, you are very likely to then also be afraid of spiders. And if that correlates to a scary instance with a spider, then you're set up to have a longer-term bad response. And then, of course, sociocultural factors. So culture really helps shape what's important to us. And if something is essential or critical in your culture, then you might worry about that. So different cultural norms will influence people's worries, and if it goes too far, we then start seeing our phobias and our particular anxiety disorders framed around whatever that culture is weighting most heavily. So some big ones could be the fear of being fat for Western culture, or the fear of offending someone, which is really important for, I think it's in Japan. But every place is going to have their own priorities, their own things that people are going to worry about. Right, and I did mention before, but this is the written for the sex differences with our anxiety disorders. So it is very, very common, usually a 2 to 1 or a 3 to 1 ratio for women versus men with these disorders. And these differences, it isn't an adulthood thing. Even if we start looking at, say, children, 7 years old, we start seeing sex differences. So this is something that happens very, very quickly. So it might be some kind of biological sex-linked predisposition. It might have something to do with the environment. Maybe there's less power and personal control for women in different societies, and that loss of control leads to more feelings of anxiety, which we mentioned for stress is really important. I mentioned the cultural norms for expressing emotions. So maybe it's a little bit of all of them, but it's really, really hard to separate those factors out. So we just acknowledge that there are differences, and it might be a fault of the diagnosis, it might be a fault of the culture, it might be a biological thing, it might be a lot of stuff. And then we get into obsessive compulsive disorder, and then post-traumatic stress disorder. But yeah, our reminder being that these are no longer technically anxiety disorders, but share quite a few pathways that are involved. So with obsessive compulsive disorder, this is when individuals have persistent, uncontrollable intrusions of unwanted thoughts and urges to engage in ritual behaviors. So we have the thoughts and the behaviors as two main components, hence actually the name, obsessions and compulsions, where the obsessions are our cognitive component, repetitive, unwelcome thoughts, sometimes intrusive thoughts, and then the compulsions are repetitive behavioral responses that we're going to make, and usually the intention is that you engage in the compulsions because completing them actually helps you feel better. It helps relieve some of the anxiety that came from those obsessions. So we end up with this kind of feedback, again, with our negative reinforcement, where the more you engage in the behaviors, the better it makes you feel, the faster you are to engage in them the next time to help alleviate that. The problem being that you end up doing them more and more and more and more until it starts becoming really problematic for your life. One of the biggest differences here is that there's equal prevalence between sexes. We don't have that same sex difference we've seen in literally all of the others. So one of those reasons for why they've separated this out. This OCD can include a bunch of other subdisorders. So body dysmorphic disorder, that's when individuals obsess over a perceived physical flaw. That counts here because they would obsess and engage in compulsive behavior centered around a specific part of their body. We can see skin picking disorder is another one, self-explanatory, again, hyper-focus on their skin. And hoarding disorder actually also counts as OCD as well. Because they are obsessing over these different items that have little or no value, and they are compelled to keep them, to hoard them, to categorize them and stack them. So yeah, we see a bunch of different instances of this. And this is one of those that falls in that sort of 2 to 3% of the general population will receive this diagnosis over their lifetime, so fairly common. And if you are curious, there's actually a couple of different brain areas where we actually know how this works, where they have two main focuses. We have two models, one being our executive dysfunction model, and it says that it's a problem with our executive dysfunction, where we're not able to control our impulses. So it's an issue with behavioral inhibition. Sort of suppressing our desire to act on things. And so because of this, they say, it must be related to our prefrontal cortex because that's where our impulse control is residing. So our prefrontal cortex is related to evaluating a situation and figuring out what we do. It also has a very close relationship with our caudate nucleus, which is on here in the middle, right in there. But it's part of our basal ganglia, and it links very closely with our prefrontal cortex, and it helps sort of integrate prefrontal cortex activity with our limbic system. One of the problems with this theory is that there's a lot of mixed research where sometimes they see that there's a difference in activity levels, so sometimes it's more or less active, sometimes it's neither. They tried to get into caudate nucleus volume and see some differences, but not all studies support that. So there's some uncertainty here. Some people have tacked on that, oh no, we should absolutely imply our thalamus being involved because our thalamus helps send off our sensory information. So maybe we're attributing incoming sensory information, and that's why we're having problems with behavior. And that one has less of a logical argument, but more of a physical research support side, where there's a lot of research that actually shows increased thalamus activity for OCD patients, but we're not positive why. So that's frustrating. So they're like, okay, well, let's look at our other model. Our other model is our modulatory control model. And we're gonna say, okay, we'll look at places that tend to modulate our activity. So we're still in our prefrontal cortex, at least that part, the logic still holds. But now we're looking at broader connections. So here we're saying, okay, so we're modulating our responses and maybe we have some increased activity that's leading to, say, the thoughts. So higher activity in our prefrontal cortex would be things like our brain sort of filtering through information that maybe we don't need right now. So we're having impulsive thoughts because there's too much activity. Trying to explain the fact that we have some studies that say too much and some that say not enough activity, a little bit of both. And we do actually start seeing that, yeah, there is some involvement there. And they actually say that our, this part here, our orbitofrontal cortex up to our cingulate gyrus, so this white arrow here, that pathway typically is more active when people are on the obsession side of the disorder. And if we then swing it around and start looking at, let me see if I can get it to, there we go, these arrows, these guys are the compulsions, where we get the prefrontal cortex into our caudate nucleus and the thalamus into some of our actions. So we're involving, a lot of the frontal lobe is active here because the orbitofrontal cortex is still frontal lobe. Prefrontal cortex is that evaluations. So it's almost like it's integrating the other theory into more of an explanation for the obsessions. And these pathways and the fact that information seems to flow slightly differently, that has more evidence, but there's still a lot of uncertainty here. So we think that the obsessions are related to that orbitofrontal cingulate pathway, and the compulsions are the prefrontal caudate and thalamus pathway. But there's a lot of unknowns. We're not positive on a lot of counts. And then for post-traumatic stress disorder, we have this idea that it's our enduring psychological disturbance after experiencing a traumatic event or events. And we've mentioned this before. We mentioned it in our stress thing, where we said that we can have things like distress and flashbacks, depression, anxiety, insomnia, and other things. I mentioned flashbacks, feelings of detachment, inability to concentrate, overreactivity. So a lot of stuff that's, again, kind of making us think like we have an overactive fight or flight response. And this is another one of those updates where we moved it out of just an anxiety disorder, but the definition and the considerations here changed dramatically with the DSM-5 update. So now we have not just physical trauma, but also emotional trauma. And we can look at both direct and indirect experiences. So if you've heard of CPTSD or complex PTSD, that's when we're looking at not a single physical event that's causing it, but maybe multiple events. And now we can see these sorts of effects from, say, emotional trauma as well. And this actually helps explain a lot of things like, say, someone growing up in a really rough childhood. CPTSD does a really good job of explaining a lot of those effects. So it can be short or long-term exposure, a single event, multiple events. It can be physical, emotional. There's all sorts of different options here. And this is from that expanded definition, hence it getting its own category now. Whew. All right, lots and lots of information there. But next we get to do our mood or affective disorders. And we've used that term before. The affect is the mood of something. So either term might be used depending on the individual. We're going to look at depression and different categories of depression because depression has multiple types. Then we'll get into bipolar disorder, seasonal affective disorder, and I think there's a couple of other stragglers that get mentioned very, very briefly. But with depression, this is one of those where the way that the term is used in society, when we talk about depression, people kind of just assume you're sad, you're blue, you're having a bad day. But as we figured out, clinical depression is a lot more than just being in a bad mood. So we're looking at something where the frequency, the intensity, or the duration of our symptoms is going to be out of proportion to a situation that's causing it. Very similar to what we saw with anxiety, but now we're looking at our mood being affected. And our two main types of depression are major depressive disorder and chronic depressive disorder, where chronic depressive disorder is usually a far less intense version. So if somebody doesn't tick all the boxes for major depressive disorder, they might get the chronic depressive disorder diagnosis. But for the most part, it's sort of major depressive disorder is what people are talking about within psychology if they mention depression. And so the way that depression or major depressive disorder works is that we're having these persistent feelings of sadness and despair. They start losing interest in things that used to bring them enjoyment. We can sometimes call that anhedonia, which we'll actually see related to schizophrenia later on. But it's a reduced ability to experience pleasure or enjoyment from life. And for a major depressive disorder diagnosis, you'd have to have one of these events lasting for a long period of time. If it's just a couple of days, it doesn't count. Might stick it into chronic depressive disorder if it recurs often. But if we have long periods, say weeks or months or even years, that's when we're falling into that category of major depression. This is another one that is far more common in women than men. So women are more than twice as likely to suffer from depression than men are. And when they do suffer from it, they get it much earlier. So for women, they tend to have their first episode of depression in their 20s, whereas men don't tend to experience it until their 40s. So there's a massive difference there. So not only sex difference in quantity, but also when it develops, which is really interesting. This is another one of those that seems to be changing really dramatically with the times. So as people are learning more and getting access to diagnoses, we're starting to see that the occurrence of this is very much on the rise. And so there's, of course, the debate of, is it that, the world is getting worse, or is it that more people are having this disorder because of interactions or genes, or is it just that we're diagnosing people now because we know what to look for? Possibly a little bit of all of the above. If we start looking at so people born after the 1960s are 10 times more likely to experience depression than their grandparents were, even though their grandparents have had much longer lifespan, if we were looking at cumulative life experience. But also, if we start thinking about it, their parents would have lived through like world wars. So to have this massive increase in likelihood, there's probably a lot more going on. And just like we broke down our components of anxiety, we can do the same for depression. We can have emotional, cognitive, motivational, and somatic symptoms here. So the emotional side of things, that makes sense, a negative mood state. So maybe you're sad, maybe you feel hopeless, maybe a little bit of anxiety, unable to enjoy things. For the cognitive side of things, we start seeing a lot of negative self-thoughts. And there's actually, with depression, sort of a depression spiral, where people tend to think more negatively as they get more depressed, but those negative thoughts then make them more depressed. So we get this feedback cycle where it gets worse and worse and worse. So we'll see that you start thinking negatively about themselves, about the world, about their future, and that can be very problematic. They tend to focus on things like feeling inferior, feeling like a failure, being pessimistic about outcomes, and they can also have a lot of difficulty concentrating because they're so worried about so many other things. With our motivational symptoms, they might not be interested in things that used to hold their attention because things aren't bringing them joy. They might not be motivated. They might have trouble starting tasks. And then for our somatic symptoms, this is more of our physical stuff. So problems with eating, so they don't want to eat, or they might eat too much because they're looking for something to make them feel better. They might have troubles with sleep. So they might sleep too much or not enough. There's a lot of that here. They might have no energy, but then also not be able to sleep properly. And all of this ends up dramatically affecting things like their weight, where it might go up and down pretty dramatically depending on other habits. When we have individuals who suffer from major depression, there's kind of this big divide in how people progress from there. So with those individuals, about 50% of them, they will have another episode. So a single long-term exposure to depression is sufficient for a major depressive disorder diagnosis. Most people will have recurrence, but 40% of them will never have another depression episode. So for some people, it's this is going to happen repeatedly, and almost half of the others are just saying, well, no, they're never going to do it again. So it might be a single event that led to it. And then there's 10% of people where once they have that one episode, they tend not to recover. So our 50% where we have recurring episodes, they tend to recover in between. So they can have periods of normal functioning, normal mood in between, and those can go on for months or years. And then something happens and they will have another major episode. So there's, three very, very different outcomes. So our prognosis here is a lot more difficult. Our next section is bipolar disorder. And this is one of those, again, where we didn't necessarily, or in society, we tend not to talk about it as multiple types of disorders. Typically, when we mention bipolar disorder, what we're actually talking about is bipolar I disorder. And this is when we have periods of depression that alternate with mania. So our symptoms of depression that we just mentioned, that stands, but now we also have sort of the opposite end of the spectrum, where mania is almost exactly opposite to everything. And in fact, I pulled this slide where we get to see our emotional, cognitive, and motor effects or symptoms for mania versus depression. So the mood thing, we can go from very gloomy and hopeless and withdrawn all the way up to elated and euphoric and impatient, very sociable. With our cognitive things, we can be slow and worried or impulsive and talkative and overconfident. So again, swings dramatically in opposite directions. For the motor side of things, we can have less activity or less energy, difficulty sleeping, or we can have too much of all of those things. So bipolar I disorder is a disorder of extremes. And for a little bit of terminology here, this used to be called manic depressive disorder. So if you've heard of that, same thing, just renamed. So bipolar, meaning that we have our two facets, the mania and the depression. Because of that logic, sometimes they will call major depressive disorder monopolar depression, because it's only one facet of the same thing. And the mechanisms that underlie the depression side of things, whether it's bipolar disorder in a depressive episode or just depression, they actually seem to come from the same source. So similar underlying mechanisms, but here we alternate with mania. And having a single manic episode is sufficient for this diagnosis. So yeah, it's an interesting one. In this one, this is another weird one because men and women are equally likely to have this disorder, whereas depression was more women, here it's equal. And about 4.5% of the population will have this diagnosis at some point. We also have another type of bipolar disorder, bipolar 2 disorder, where we have depression alternating with hypomania, which is effectively like a baby version of mania, so it's not as intensive. So the reason why we typically don't talk as much about bipolar 2 disorder is because the extremes are less extreme, and so it tends to be not as detrimental. And it might just be diagnosed as depression because if hypomania isn't that different from their baseline, then they might never notice that there is a swing. So it might just be a depressive episode versus your in-between episodes. So it's kind of a diagnostic issue more than anything. But yes, so that is a possibility. And then seasonal affective disorder. I like mentioning this one because where we live, this is actually really, really common. So the further north you are and the bigger the swings in day-night cycles, the more affected the population is. But seasonal affective disorder, or SAD, is a pattern of depression that basically follows our seasons. So it is a circannual rhythm where every year we go through cycles. You can actually find that regular major depressive disorder also cycles with the seasons. It tends to be worse in the winter and better in the summer. And that's possibly due to things like exposure to the sun and a whole bunch of other things as well. But yeah, so when we don't have enough light, we tend to sleep more and have less of an appetite, almost like we're in hibernation. So yeah, it's mostly due to that reduced day length, reduced daylight, and it leads to an increase in depression. And one of the ways to treat it is actually phototherapy. Sit people in front of high intensity lights for a couple of hours. So this is one of those things where I learned very quickly, coming from somewhere much further south, that in the winter I need to go outside in the middle of the day because when I was working 9 to 5 and never seeing the sun, it was very problematic. But yeah, for about 10 to 20% of people with depression, they also suffer from SAD, so it tends to co-occur quite a lot.